foundations for theory. So I'm glad that people who are here could be here. I know some people had to rearrange things to be with us tonight, and that's a good thing. And then I think you'll kind of get the format for what we're going to be doing with theory for the next couple of weeks. So let me just wait a few minutes to make sure that everyone's here. We have 10 people here because it tells us. Yeah. And maybe a couple people. I have that at 7 o'clock right now. Is that right?
Yep.
Okay. So I like to start on time, and those that are joining us will join in, I'm sure. And so just once again, if you can activate your cameras, especially the people who are answering the discussion questions, that would be helpful so we can see you. And then as we're taking turns in and out, after you've answered and you're no longer, on the list, if you can turn your camera off so that other people who are answering can come on, because our screen will only accommodate 6, I think it's 6 pictures at a time. All right, so we're going to start exploring our discussion tonight about theory, and the first few students who will be calling on, if you look at your list of attendees, would be Amanda, Angela, Angie, and Cassidy. So if you guys can get your pictures, your cameras up there. There we go. How well this is working out. We've got Whitney. And I think, Whitney, did you just join us? Is that, oh, can you hear me, Whitney? I know this will take a little bit of doing till we get this together, but okay, so we got Amanda, and then if Angela, Angie, Cassidy can get on there. Good, great. And so what we're doing, just for those of you who just got on, click open your attendee box on the control panel so that you can see your name, the names of the students in the class. And we're going to go in order down that list, answering our questions, starting with Amanda, Angela, Angie, Cassidy, and so on. Click on and off after you've answered, or, you don't need to come back on every single time. But I think this will give us the closest thing we're going to get to a real live class discussion in a distance class. And for theory and stuff, I think it's really helpful to do that. So first of all, I just wanted to talk a little bit about the textbook that we're using for the class. Karen Glantz is noted in the field of health behavior theory, writing, and behavior change. And as you can see, the textbook is divided into sections where we talk about first we have the intro, we have the part on theory, and then she divides it into models that are about individual health change, individual health behavior. Then, there's a beginning and an end to that and some examples. Then she goes into interpersonal. So in other words, the circle is widening now, not just my own individual behaviors, but how my health behaviors function within a social context, a small social context like a family or a social network, small s, small n. And then we go to the next part of the book where we talk about community and group models. So that's the first thing I want everyone to notice, is that health behavior theories aren't just for every situation and every single thing. There's transference of theory to different behaviors in different situations, but some theories are really geared towards predicting how an individual responds. Some are taking other factors into consideration, like self-efficacy, for example. And then we have the big macro kinds of changes that look at how an entire community or system is affected and how we affect the health behavior of community, and that policy and governmental, social kinds of programs have changed. Okay, so with that being said, let's start off our behavior or health behavior questions, and we'll have Amanda up first. And so, Amanda, we were talking about in general how have major causes of disease and death changed in the U.S. in the past 100 years. So, if you could hit the high points for us on that. Maybe we lost Amanda. I don't see her up here. Are you there? Oh, your camera's not on. Okay. Oh, there she is. Amanda, can you hear me? She doesn't look like she hears us. Right. Okay, let's hang out and have Angela talk to us about that.
I just reestablished audio. This is Amanda Trout. Can you hear me now?
Yep, now we got you.
Okay, I'm sorry. I lost audio connection and I had to restart everything. So
that happens.
Sorry about that.
That happens. Go ahead, take it away. We're gonna.
Okay. Did you ask me about question 1?
I did. I asked you what you thought about how death and disease have changed in the last 100 years, because we're going to just set our foundations for what's happening in health, and then we'll go on to health theory. Go for it.
Okay. Sure. Yes, I apologize again. So what I found out was that 100 years ago there were many more children dying from infectious diseases, especially children under the ages of 5. If they got diarrhea or they had tuberculosis or pneumonia, there weren't the treatment options that there are. So there's a lot less stuff occurring now from infectious diseases, and then the leading causes of death currently are heart disease, cancer, lung disease, and diabetes. So they kind of rank at the top of the list. More of the chronic diseases.
Right, absolutely. So these changes in, sanitation, acquiring vaccines, all these sort of things we put into the infrastructure really shifted the focus from acute diseases that took people early to the chronic disease model. And what are, some of the things about those chronic diseases? Any other comment on that? Or I think everybody's in sync with what they are.
Mm-hmm. Well, the second part went on to go over like the behavioral aspects associated with the chronic diseases, and just I think the emphasis now is modifying the behaviors and trying to prevent the chronic diseases, and just the modifiable, like there are some risk factors that you can't modify, such as growing older, or genetic factors that might be outside of control. But what are the factors that are controllable, and how can we modify them, and the behavior modification tools we can use. So we might be able to, they're more preventable causes of death.
Absolutely. And just a couple of those key risks, what would you say are the key?
Okay, they were tobacco use, diet, activity patterns, alcohol use, sex.
Amanda, can you, I think
she'll be
Amanda?
Behavior and
yeah, she doesn't have enough bandwidth. We might be able to do it. We do it? Okay. Okay, so I think what's happening is when you have your camera, your video, and all this stuff on, sometimes that you don't have enough web power. So we'll put Amanda on hold for a minute, and does someone else, Angela, can you tell us what risk factors you have there? Yeah.
Can you hear me? Okay, great. So for question 1B, that's what we're on still?
Yeah.
Okay, I think, so I had what Amanda was, I think, trying to say.
Yeah.
That lifestyle choices like tobacco use, diet, exercise, and alcohol consumption are the key factors related to chronic diseases, which are now more prevalent. And so that's why health education and health coaching, which we're learning about, is so important, because we can help people make these healthier lifestyle choices.
Good. Yeah, so the four that keep coming up over and over again are alcohol and tobacco, poor diet, and we can define that in a lot of different ways. What poor diet means: not enough nutrients, too many calories, too much saturated fat. But in general, diet, alcohol and smoking, as we said, lack of physical activity, the sedentary lifestyle, and also, another one that's coming up and present is sleep, lack of sleep, stress. So that sort of other part of the wellness wheel that's a little harder to get our hands on, but that rest, relaxation, sleep, those kinds of behaviors. And what's interesting to me is that those same risk factors kind of repeat and repeat for many of the chronic diseases. So once we get a handle on those, 4 or 5 risk behaviors, we're really managing a whole array of disease. Good. Would anyone like to add to that? Or do we get everything for everybody there? Okay, so Angela, why don't you continue with part C as long as you're up? What do you think about, have we made progress?
Well, the textbook noted some achievements in public health. It specifically noted the decrease in the number of people or adults who smoke, which is usually noted as a big public health achievement in our country. And some other ones or improvements noted were decreased deaths from heart disease and improvements in related biomarkers like blood pressure and cholesterol. So people are making better choices in their health behavior to evidence these outcomes. There's fewer deaths from cancer. More adults are meeting dietary recommendations. And there's fewer deaths from alcohol-related motor vehicle incidents. So more people are choosing not to drink and drive, I guess.
Yeah, so obviously some public health campaigns have worked and have been successful. And then Angie, what about things that have actually stayed the same or gotten worse? Any notables on that?
Some of the information that I saw said that really the heart disease rates, cancer, hypertension, and obesity have remained steady or increased. So we have made some headway in some of those, but there are some areas where we still could improve greatly.
Right, so it's interesting to me because blood pressure and cholesterol have gone down a little, I think probably because of awareness and screening, and that's what Angela was mentioning. But yet death, total death, so this is the difference between morbidity and mortality, people living with risk versus, death from heart disease, actually staying pretty constant in the last 2 years. What was that? Feedback from somebody. Oh, thank you. You stopped it. So those things have stayed kind of constant. Cancer rates have actually gone up for certain kinds of cancers. So that's interesting. And of course, we all know how badly we're doing with weight control, right? And obesity. That's still kind of level. The peak is leveling off, but the trend is just soaring. So that's all very interesting too. Anything else you want to comment on, Angie? on that?
No, I agree with the other information that Angela presented about the cholesterol going down and smoking cessation, and how those campaigns have been really powerful in decreasing those numbers. And if we can find ways to incorporate some of that into obesity and some of the other areas that need work, that would be the key, I think.
Right, and you know, they say now obesity is now what smoking was 20 years ago. So we started this huge campaign on smoking where it was banned from media ads, print ads. We started putting lots of money into public awareness, quit lines, you know, the 1-800 numbers, resources to quit, fined the tobacco companies, finally used that money to do public health, prevented smoking in almost every public place you can think of. And so it was a concerted effort to really attack that problem. And so now obesity is kind of just coming into that recognition phase where now you start seeing the things to bring that to awareness, change portion sizes, you know, don't let people supersize kid meals, things like that. So following a similar track. So kind of look at these parallels in different health behaviors as we're going along, because you'll start to see patterns and trends. Okay, so let's go down our list a little more to Cassidy. And could you answer for us? Now we're going to move on to the second part, which is theory. So talk about health, now theory, kind of putting them together. So were there any definitions of theory that really spoke to you or that you liked from the text that we have?
Yeah, theory's kind of interesting to me, I guess, because it's more of like your opinion, but people try to like put a lot of studies and scientific behind it. One thing I thought was interesting, or it kind of applies a lot to a majority of people, is like the inflammation theory, where a majority of the society links the ideas of being healthy to like the media or what they read on a book. Like if you went up to like an average person on the street and you were like, what do you think of when you think of being healthy? They think of like going to the gym or eating a salad or whatever, but in reality it depends on like how much you work out or what's going on your salad, or it's more like intricate, I thought.
Okay. Anyone else want to add theory definitions from pages 26, 27 of our text that resonated with you?
Hi, this is Eric.
Go ahead.
Hi, I probably misunderstood the question. So my response was, it said, which one do you relate to? I thought we were looking at a definition of just theory, and so I said I most related to the concept of it being a mix of connected standards and explanations and proposals that kind of come together as a systematic approach to explain something.
Good.
Not confirm, but explain something. And the two components that the theory is a mix of concepts, and that theories are not static. I kind of related to a major theory that most of us know about, the Big Bang Theory.
Right.
Which has really driven so much more scientific understanding. I mean, it's physics, chemistry, biology levels. So I really see theories as, you know, constantly dynamic, and also just a mix of those, you know, the standards and the thoughts that human beings have to try to explain something.
Great. I love that. And I think that, yeah, it starts with maybe someone's opinion or someone's idea, someone's attempt, if you will, to put different concepts together. And then, of course, as we know from science and research, those pieces have to be tested through scientific method to see if the theory holds up. And, you know, that's a challenge for behavior theory, because it's never, completely, what do I want to say? We can never be completely sure because it's human behavior. So there's always a little bit of interpretation in that. But I too like the fact that theory is always evolving. And so it's good that it's fluid and flexible because as we get new information, we're going to incorporate that into existing theory. And so you're going to see a lot of that with the health theories. We had a particular model, we thought it was like this, but then we get a new model, we take a variable from there, and we start to put that into an evolving theory that explains things better. There's a lot of work to be done in testing theories as well. So you have those definitions. If anyone isn't with me, I'm on page 27 of the text, and it gives various authors' point of views, definitions of theory. Probably that one that you just talked about was from Babby, systematic explanation of facts. So take a look at that if you're still groping with what we're talking about here. Okay, so let's move on a little bit then. So what behavior models have you guys used, and do you feel versed in? And let me go down my list a little bit here and see where we're at. Courtney, Jen, and Michelle are up next. So, Courtney, do you have want to tell us about theories you've used or feel familiar with from health behavior change?
So the health behavior model and the trans theoretical model, I'm familiar with both of those only because I was studying for the RD exam, and so you have to remember and learn those. I never saw the health belief model actually being used, but the trans theoretical model, stages of change, whenever I was in my internship and I was observing the outpatient dietitians when they use motivational interviewing, they often use this model to figure out what stage the client is actually in, so then they can work towards getting them to the next stage and help building their confidence to get to the next stage. So I really like that model. That's really the only one I've had experience with.
Yeah, and you're not alone. I think that's the most popular model right now. Let me just throw that out to the class in general. Has anyone worked with other models than the trans theoretical model?
I just
Go again?
Nope.
Nope.
Okay.
I can just say this is Amanda Trout again. I'm kind of lost audio now. I'm on my phone. Hopefully this is going to work.
Yeah, that's
the only other one I have experience with the stages of change, using that with adult weight management. But the only other one, the social cognitive theory, I was just able to get a little bit of experience using through a previous class I took with you.
right.
When I had to use it I did a presentation in preschool children to help them learn how to choose water instead of sugar-sweetened beverages. So we used the social cognitive theory to pull in like a lot of the different levels of, I'm trying to remember here. I think it was, bringing in what the parent's responsibility was, what the child's responsibility was, what the teacher's influence was, how a dietitian could influence them, so all the different levels of influence on the children to help them to choose the behavior that we wanted, which was water instead of sugar-sweetened beverages.
Good. Yeah, I remember that as well. That's great. I'm happy that you brought that up. And
I also read a little bit about the social marketing model.
Oh, good.
In chapter 19, just because I wasn't really familiar with different theories. I hadn't really used them in practice. So social marketing, just because I work in outpatient dietetics, and so I know that I need to depend a lot on the marketing team in order to get anything that I want public, draw customers in, draw consumers in, and so understanding what your customer base is and then how to reach them effectively is really necessary, especially in the outpatient line of work.
Absolutely. And anybody who's doing even if you have a personal practice, that marketing chapter, social marketing, is a great chapter. If you're not from a business background or a marketing background, you'll understand the concepts of that right away as being very important. The 5 P's, product, place, promotion, price. I don't know, there's one more P, I can't remember, but it's all part of the package of getting your wares out there to the public. So that's a great chapter. Jumping ahead, but has everyone used stage of change model or at least heard about it? That's the most popular right now. Yeah.
Yeah.
Yeah. And Meg, this is Sharon. In the diabetes area, we use the health belief model a lot.
Oh, good.
Especially when working with diverse cultural groups. The essential part is understanding what do they believe about the disease state. And a project we're working on right now with that model is adherence to medication.
Oh, excellent.
So we're using the constructs of that because that's a huge issue that it's not a disease state, but it has an impact on all the other disease states when they don't adhere to medication.
Oh, that's super. I can't wait to hear more about that. So, anyone else want to comment on theories while we're just sort of going around? Okay, so last week I had you guys do the Wheel of Health, and I read through all the discussion board comments this week, and everybody really loved it, and most people hadn't used it before, so I'm really happy that I was able to bring that to you, because it sounds like a lot of people might use that in their workplace or with new clients or just a variety of settings. So now that you've had the benefit of doing that, part F of this question, reflect on your own personal health philosophy. So we're at Jen, I believe. Jen,
Yep.
what do you think? I'm sure you have a personal health philosophy all worked out, right? Coming from
Well, I think I said in my answer that it's something I've been thinking about for a really long time. I mean, it's partly why I'm here, studying nutrition.
Yeah.
But because the whole reason that I ended up in dietetics was because I struggled with my weight for a really long time. And then also, on top of that, for those that don't know me, I have chronic neck and back pain that has been a real burden for a really long time. So yeah, I spent a long time thinking about it, and of course, yeah, I don't have all the answers. I'm not in this book yet, Meg.
Oh, okay.
but I think what's most important to me, at least in terms of having a relationship between practitioners and patients, is that there needs to be a true partnership where the patient or client, however you want to refer to them, feels like they have autonomy over their goals, and that they're listened to, and that it's a real equal partnership. And I feel that even more strongly now after working in the hospital, because the term non-compliant gets used so loosely.
Yeah.
And even though, yes, there's people that are repeatedly in the hospital because they aren't following the medical regimens that are being prescribed to them, but sometimes I wonder, has anyone asked them, do you even want to be on dialysis anymore? What do you really want out of your life? Do you, how do you feel about the fact that you're lying in this bed with 2 amputations and you're clearly depressed? Have you talked to anybody about it? Like, all of that gets left to the side and they're being blamed.
Right.
Like, I really liked in the first book when he said that people are responsible for their wellness, not their illness.
Right.
And I really liked that a lot, and I wish that more of healthcare came from that viewpoint.
That's well said, Jen. Good.
Yeah.
Now, and also, here's a philosophical question. Can that person who's in the bed with the 2 amputations still experience health and wellness. And
Yeah.
from our traditional Western medical model, a lot of people would say, no, you're not healthy. You're down at that third end of the continuum. But a lot of holistic practitioners would say, absolutely, this is where your spiritual health comes in and your social, connectivity, and your, maybe that person has a hobby or they're a leader in their field in some way. Their intellectual health is at its peak. So I think that's a really good way to think about it. And I love what you said about the compliance. That's a word I really try not to use.
Yeah.
Anyone else want to comment? Michelle, you're next in our. Do you want to make a comment about that health definition at all?
I guess mine, it kind of went, I wrote down what I was thinking first, and then the second part was according to the health coaching psychology. But I've always felt that a healthy body and a healthy mind is what makes you whole and would lead to success and happiness. So, your body needs to be healthy. You need to eat well, exercise, all that good stuff, and keep yourself well. But if your mind is not well, then overall you won't be. So I just really think that, everything in moderation, and you have to do the whole body. And laughter is the best medicine. So really takes a load off your mind.
Yeah, and I don't think here again that mind, mental component, which might include cognition, intellectual, mental, we could say mind, body, and spirit, and that would get some of those other social kinds of things in there. Once again, in our culture, we haven't really focused on that aspect as much as the physical being the only dimension of health.
Right. I think that it's very social, and that if you look good, then you're healthy. So if you're thin and, you just look good, then that means you're healthy. And those people, if you really sat down and talked with them, they probably aren't so healthy in their mind, and it will weigh on them eventually.
Okay, thank you. Would anyone else like to comment or share their health definition? Okay. Cassidy? Whitney?
Sorry, yeah, I was just going to say I liked how the coaching philosophy used relational skills, because that's something that I feel always rushed in my counseling sessions, that I have to get a certain amount of information across, and a lot of times the relational skills have to fall to the wayside. And so just seeing how important that is so that we can be effective as counselors, that's something that I really took away from that.
Great. And the really professional leaders in the field of health coaching really do believe it's possible to bring little bits of that coaching relationship into even the briefest interaction, so that you can at least try to touch on some of those keynotes to keep that relational part in there. So yeah, very important. All right, well, let's dive into the first theory then. Our first theory, remember again, this is individual health theory. So we're looking at how a person, one person, and what changes within them to motivate health behavior change. So let's see who we've got next. Nicole. Is Nicole with us tonight?
Yes.
Okay. I can hear you, and I don't know if you want to just have your voice, that's fine. And if you want to put your camera on, that's fine. There's room for you. Let's just look at the authors, the founders of this theory, and just do A and B, because that's pretty brief, and the development of health belief model. What did you find for that?
So I found that the health belief model, as I was reading, it was initially developed in the 1950s by some social psychologists, and that it was used to originally used to explain the widespread failure of people to participate in programs to prevent and detect like chronic diseases. Once it was developed, the social psychologists were developing this approach in order to understand behavior that grew from learning theories. I read that it was derived from two major sources. There was the stimulus response theory, and there's also the cognitive theory.
Good. Yeah, so basically the guys who get credit, and what I would recommend to all of you, just to develop some tools for your own learning, is make a little table for yourselves with the theories across the top and these pieces down the side. And you know, it's a good sort of habit of mind, so to speak, to just kind of lay it all out and look at these theories together. So you want to be able to remember the key authors, just so that it helps you to recall who were the guys that pioneered this. And as Nicole said, they were social psychologists. Hochbaum and Rosenstock are the two that really did, you know, when their names are attached to the original research. There was also a third person, Kegel. Those were the names. And then you'll see that as these theories developed and were applied to other things, different authors developed the theories. So Becker is another one who started to write extensively on the health beliefs model, and Maimon, M-A-I-M-O-N, they started to take it up. So you'll see this evolution of different authors working with the theories on different topics. And as Nicole said, they were with the Public Health Service in the 1950s. It really started out with the tuberculosis screening program. Because if you recall back then, that was a big social health problem, public health problem. We had vaccines, but people had to get screened, you know, or we had treatment rather, but people had to get screened to find out if they had tuberculosis before they could avail themselves to that treatment. And what these guys were so frustrated, if you go back and read the historical, you know, their story, you know, they're trying to get people to a really, you know, important, stop this disease, which is highly contagious. If we can just get enough people to get screened and get treatment, and we can stop it in its tracks. And what they found was that people were so resistant to getting the screening. So they wanted to figure out why. You know, why was that? So let's go on to the constructs that they developed. And as you're going to see, every theory, it might have like a little graphic representation, and then it's going to have its particular constructs or variables, if you will. So let's go next on our list. Where's my mouse here? There it is. Let's see who's coming up. Whoops. Where am I going, Jeff? There we go. So Sharon's next. Sharon, then Taylor, and then Whitney. So Sharon, what key concepts, and you're working with this with medication compliance, so this is a perfect question for you. What are the perceived constructs that you think are important?
So there's perceived susceptibility and severity, which come together to make up what they call the perceived threat. And then there's the benefits and the barriers. So the benefits and barriers would be like, why should they do this behavior? And the barriers are what's standing in their way of doing this behavior. And cues to action kind of came later in the development of the health belief model. And those could be anything. It could be a letter from their physician to remind them to go for a mammogram. It could be a call from the pharmacy benefit program like CVS to say, hey, it's time to renew your prescription. We're also using things like emails and text messages to cell phones to remind people to take their insulins at night. And then self-efficacy, building those skills in the patient so that they believe that they can execute this and follow the regimen.
Good. And by the way, here's an example right off the bat of how these models evolve, because when the model was first written in the 50s, self-efficacy hadn't even been imagined yet. Self-efficacy didn't come along till the late 70s with Albert Bandura. So here's an example where this theory existed with its set concepts, and then later, after self-efficacy was found to be such a huge predictor of patient behavior, it was added back to the health beliefs model and embraced. So that wasn't there in the original model. So
yeah, and particularly important if it's a complex regimen.
yes, right. And as Sharon said, and you can see on page 49 in our book, the perceived susceptibility and the severity. So, you know, the susceptibility, how likely am I to get this disease? And the severity, if I do get it, how bad could it possibly be? So that combines into the threat. Those are really key concepts, and going back to what Nicole said, they come from behavior and cognitive theory, you know, and all of this stuff basically comes, you'll see this over and over again, but they're going to call the variables different things in different models. So I want you to look below the names of the concepts for the actual guts of it, the core of it. But it's all really kind of weighing costs and benefits, isn't it? So the perceived benefit, if I go get a mammogram, what is the benefit of that? And what is the barrier? What's the downside? Gee, I might have to do something else. I might have to, you know, there might be something wrong with me, and I'll have to get another test, or it'll be inconvenient, or it'll take time out of my workday. So people are always weighing the costs and the benefits, and that goes back to a real early behavior mod theory from the work of Lewin, Lewin, that talked about positive and negative values of things. And that's part of human nature, that we're always going to weigh those cost benefits. So we'll see that come up in most of the theories. Now, notice those modifying factors, and that's important: age, gender, ethnicity. Those things are kind of hard to measure. So those are just sort of thrown into the mix in a way, like, here's all the factors that could possibly alter the key factors. And we do know that age, for example, if we're working with adolescents, let's say, knowing anybody who's got kids or knows anything about kids, what do adolescents think about their perceived susceptibility to anything?
So it's level 0.
Say immortal.
I'm invincible. I'm invincible. Right. So when we have, if we wanted to apply the health beliefs model to, say, risky sexual behavior in adolescence, do you see how that might not be a good fit? Because I don't know how susceptibility is going to play out in that population. It might be interesting to measure that, though, and people do. HIV or AIDS screening behaviors use the health beliefs model quite a bit. So let's take it personal for a minute, because I want these concepts to come home to you. So how many of you get a flu shot religiously every year? People raising their hands. That's cute. Okay. And how many people? And are there people who just don't ever get a flu shot? You can raise your hands too.
My husband.
I've never had the flu.
Okay. All right. Let's see how this model plays out for us in real life. So those of you who get it, what is your thinking? What is your perceived threat? Who wants to talk? Taylor, are you on?
Yeah, I'm here.
Yeah. Oh, I see you. Okay. Sorry, I'm looking at the wrong name. What do you think about that?
I got one this year for the first time for work. Otherwise, I probably would not have gotten it.
Good. That's honest.
I don't know. I've just never really felt the need. I'm just like Cassie. I've never had it. I don't know. You would think that living out here, like in the cold, that I would want to get it, but I've never had it.
Okay, so I've never had the flu, and so my chances of getting it are slim. So notice her perceived susceptibility is low, and then what do you feel like? Well, if I did get it.
Well, it's kind of funny because before I got it, I was a little nervous about it. I don't know why. I was just nervous. And I talked to my grandma about it, and she was very adamant that I should get it. I should have always been getting it. She gets one every year. And so that was kind of an interesting.
That's very interesting. So we see some of the modifying factors. Grandma always gets it, maybe because of her age, maybe because of her personality. Maybe she's a very preventive type of person.
Oh, yeah, she is.
Not take a risk. Let's err on the side of caution. Maybe her knowledge about the flu vaccine, and maybe you hadn't really been thinking about it until your employer told you to get it. Yep. Who else wants to comment on this relationship?
I'll say something.
Go ahead.
I'll say something, Meg. So I never got it until I started working in the hospital and it was required. And then at that time, I felt fine about it because I'm concerned about my patients. I wasn't so much concerned about myself. I guess I never really thought of myself as being at risk. But then once I got pregnant, it became extremely important to me. And now so much that I want my husband to get it, who has never gotten it before. So I guess to me it's more about my daughter than me, which is interesting because it's a whole new thing for me.
So your perceived benefits and barriers have really shifted.
Yeah. Yeah.
Because you're thinking about benefits not just to you, but to your patients, your daughter, your family.
Yeah.
Right?
Yeah, it's interesting.
Very interesting. So that's the way we can make these models come alive, is for us to really think about what groups do they work in and how does it capture what people really think? Does anyone else want to comment on that?
I will. I am a school nurse in a preschool and kindergarten school building. And in the state of New Jersey, it is mandatory that if your child does not turn 5 before the end of December, that they should need to have a flu shot if they are in any kind of a preschool program, whether it be a daycare or public school.
Go to Jersey, huh?
Well, it doesn't make a lot of parents happy. Yeah. And New Jersey also has a very lenient religious exemption rule for law. So I will often have parents write a letter and say, my child will not be getting the flu shot because it's against my religion. Yet they've received all the other immunizations. But that's what they are allowed to do. So being that a large majority of my school population is required to get it because of their age and being at higher risk, I get it myself, protecting them, but also protecting me since I'm such a close contact caregiver with them.
Yep.
My husband is against it because when he was in college, he had to get it, and he always got the flu. So he doesn't get it anymore. Last winter, he actually was diagnosed with the flu for real. And so he said, I'm going to get a flu shot now, but now it's time for flu shots, and he's not going.
So what happened to him was his perceived threat increased after he actually got the flu, which I believe I heard a story last year from Debster about that same experience. And once you get a real bad experience with the flu, your perceived threat goes up, and then that compels you to act. And notice how sometimes it takes this critical mass for something to get you over the barrier where you're actually going to change. So that was my experience as well. I never used to get it when I was younger, and once I started being on the faculty here, I would get sick every year from all my students. So I started getting it religiously.
Right.
Right. So we have the modifying factors that we talked about, those core individual beliefs, which notice can really flux in so many directions. And then whether or not we take that action or not, you know, it depends on how those different beliefs line up. And then as Sharon was saying, maybe getting that extra little push, that cue to action. So if you go to your annual doctor appointment and they say, would you like a flu shot while you're here today? And it happens to be flu season. Here at University of St. Joseph, they have an employee wellness day, and they give free flu shots to the whole campus, and that makes it easy. So that's my cue to action. I put that on my calendar, and then I'm all set. So,
and sometimes the symptoms can be the cue to action too.
Good point. Yeah, like you're working with diabetics, right, Sharon?
Right.
Yeah, so, you know, as they're getting sort of sicker and having manifestations or worse and worse symptoms of diabetes, then they're finally pushed over that edge, as we were saying, toward action.
Exactly. And for different people, it's different cues.
Absolutely. Yeah. Different, you know, different belief systems are really important, and I imagine that that's why you're doing this study with your population, because it's known that, you know, sociocultural beliefs, like for example, we have a very big Latino population here in Hartford, Connecticut, and it's well known that the belief of fatalism is very common among Hispanic and Puerto Rican families. Not everybody, but by fatalism, I mean that fate or God or powerful others will determine what's going to happen to you, your destiny. So often people will say, oh, you know, I put it in the hands of God. If I'm meant to get the flu or I'm meant to, you know, get diabetes or whatever. So they kind of surrender up a little bit of their autonomy in that belief system. And that can play into health belief model as well, because if I don't feel like I can really control my destiny, then I might be less likely to take action. So that concept plays into ethnicity and socioeconomics, and also into self-efficacy, the belief that I have the ability to control my behavior, my fate. Anyone want to comment on that, what I just said? I don't know if any of you guys have populations where you see that pretty clearly.
I do. This is Erica.
Hi.
I do. I work in a population of mostly underrepresented, low-income families where you guys probably know I teach 8th grade science and STEM. And there is a very fatalistic view, typically among the Latino population, like you said, where we leave it to God, or, oh my goodness, she was hanging out over there, that's what happens, oh, she shouldn't have been over there. These are the things that happen when, you know, someone's hanging in that area, or, ooh, she's talking to all those guys, she's probably sleeping around. And I know all cultures are like this to a degree, but I hear it verbalized more often in Latino culture. And so unfortunately what happens, and having worked in a pediatrics office for 15 years as well, I've seen it there too. What happens is that we get these huge gaps in personal health care and how do I say this? Large gaps in even feeling comfortable with healthcare education in the community. Like it's kind of frowned upon if you're the one who's speaking up saying, oh yeah, I heard it was good to eat organic fruits and vegetables. It's like, wait a minute, what are you talking about? You know, where are you coming from? We don't do that. We eat this and we have.
Because people get suspicious if you bring in, you know, outside concepts like that.
Absolutely, absolutely. And this is by no means to knock any particular ethnic group. I'm of the persuasion, and so I'm not going there. But it's just interesting to see the comparison between the stereotypes, at least, or the majority of particular ethnic groups and how they approach healthcare prevention and healthcare and healthcare education. It's very disconcerting to me, and this is part of the reason why I'm taking the class, so I can kind of learn to get out there and help folks.
Excellent. All right, so let's comment then on the next part D of what are some of the limitations. With all these things being said, I think that you can see that there's some very good points about the health beliefs model. What are some of the limitations? Let's see, I guess we're all the way to the end.
Limitations. Oh.
Yeah, everyone had a chance. Right? Did you have a chance, Whitney?
I'm sorry?
Sorry? Yeah, Erica, I see you. Are you on by phone?
Are you talking to Erica?
Yep.
Yes, I'm on my computer, but it won't show up as video, so it sounds like I'm on the phone, yes.
Okay, that's fine. So why don't you tell us about that then?
Sure. I noted myself, and also I read from the authors that the HBM, they use so many, what's the word I'm blanking out? So many acronyms, I had to get used to them, but the HBM doesn't really reflect I think I wrote emotionality of individuals. It focuses more on objective perspective on human health, which unfortunately, so it's good to have the objective perspective and the data and the observations. However, we're talking about human beings, and so when we don't take into account the emotionality of different ethnic groups, like you were saying, or of individuals, we miss out on other health, other diseases, potential diseases, or other healthcare concerns. For example, if you have an individual who presents with, severe depression because their mother just died, and this patient is overweight and has recently developed prediabetes, we can't sit around talking about this individual's overweight. We can't sit around talking about the individual's diagnosis of depression without taking into strong consideration that her mother just died.
Absolutely.
So the HBM, I did not feel took that into account, which is okay for data purposes, but not for human modifying behavior purposes.
Good. Does anyone else see any other limitations or drawbacks? So Eric is saying it doesn't in person's attitudes. I also find that there's feedback on the line of some. Yeah, good, we got it. If you look at that column of just all those things that are lumped together, like age and socioeconomics, and there's a lot in there to dispel. There's still feedback, so people can mute themselves. Or I can mute you guys. All right.
If you have a phone and you mute the computer, that helps.
That's okay. All right. So yeah. So let's go back to the top of our roll then, to Amanda. And what would you say about where the health beliefs model fits on our continuum? Because that's another consideration. Not just is it for individuals or groups or the public at large, but what does it do a good job of predicting? What do you think, Amanda? She's on the phone.
No. Can you hear her though?
Oh,
did I unmute?
Hang on.
I don't know how to just unmute her because I can't see her.
We'll just do all. There she is, right there.
Yeah, that's interesting. Amanda, can you hear us?
Unmute.
Oh, we can't hear her.
Unmute this person.
She is on mute.
Okay.
Isn't she? Okay.
Yeah. Go ahead,
Sorry,
Amanda.
no, maybe I didn't.
No, can't hear you yet. Not so sure what happened.
Well, maybe like try again.
That's the.
Unmute this person. So she should be. Try talk now, Amanda. No. Hey.
Sorry,
Microphone
guys.
again.
Oh, there she is.
Is that you?
Okay, now can you hear me?
Yep. Yep.
Okay. Now the phone.
Okay. Well, I might lose one or the other.
Sorry.
Well, I have to use this to hear you. Okay, sorry, I'm having computer problems tonight. I thought because the health belief model really focuses on prevention, like a lot of times it's used for screenings or to, like some of the examples were to encourage condom use to prevent disease or pregnancy, seatbelts to prevent injury, and different screenings. So it would fit kind of on the range of prevention and health promotion because it's mostly used for understanding the barriers to preventative care.
Good. Yeah. So what it was developed on preventative care, primary prevention or screening, so that's good to keep in mind. Doesn't mean that it doesn't have application in other areas, but usually it's used for sort of, and it's strongest, let's put it that way, on looking at a particular behavior, like does someone go get a screening? Do they go get a flu shot? It's interesting to me, Sharon's using it with diabetics on medication compliance. In a sense, that's one behavior, but they have to do it over and over again. So I'm interested in hearing more about how that, is going to work out. But it's very different than, say, an exercise regimen where it's a lifelong thing, or a diet, where we see more of our next model kind of coming in to sort of take up some of the things that health beliefs model's not strong on. So health beliefs model, that cue to action, is a lot about what are the things that gets the person over, over those barriers to pull the trigger on doing a behavior, doing action. But then doing that over a really long period of time, there haven't been that many things that have used health beliefs model successfully to study that. Do you want to add anything, Sharon?
Yeah, one of our big can you hear me?
Yep.
One of our big challenges is initiating injectable medications because I work for a pharmaceutical company, so a lot of people don't want to initiate either insulin or GLP-1 receptor agonist injections. And some of that resistance comes from the physician as well as from the patient. So that's really where we're using it, is in initiating therapy.
Yeah.
But then also, because it's a changing disease state, their medication needs change over time. So maybe that's one of the reasons why we're having such a hard time getting people to stay on therapy. The average person in the Northeast only stays on their therapy for 134 days.
Wow.
So maybe we should use a different model for the repeat behaviors and then use the HBM for new initiations.
Actually, that's
so
what
that's good insight.
I would recommend. Yeah. So you're really using the HBM to say what gets people to start. In other words, they're controlling their diabetes just with diet and oral meds, and they're reluctant to start at that next phase of the injectable.
Well, what happens is their control declines over time as the disease state progresses.
Yeah.
And then we have a hard time switching them to injectables when they need it.
Yeah.
But then the other side of it is we also have a hard time getting them to take it every day. So they'll, for 134 days on average, they'll take their long-acting insulin, but then they drop off therapy.
Right. So you need another model now to start predicting them staying with it, the maintenance of the behavior.
Yeah. That's really useful. I need to think about that. Yeah.
All right. Therapy in action. That's what we're all about here. Okay. Well, that's great. Anybody else want to comment on the health continuum? And are you starting to see how these models sort of, fit a certain place, a certain time, a certain client? That's what I hope that you will get out of it. And once you have that, you're going to be able to pull these theories, in and out and realize, just like our conversation there with Sharon, gee, now maybe we need to measure something else or provide different kinds of behavioral activities that cue something else. So that's great. All right, so other disease states that use health beliefs, we talked about it a little bit. Angela, do you have any others you want to add that's been using the health beliefs model?
Is this part F that you're
referring
to?
Uh-huh.
Yeah, so in the text, it mentioned cancer screenings and risky sexual behaviors as a place to apply it. But personally, where I work, I had the opportunity to work with an organization that provides free health screenings to community members. They offer blood pressure, cholesterol, and blood sugar tests. And we were able to work with this organization to design a brochure based on the health belief model.
Great.
It addressed susceptibility by talking about risk factors, severity in terms of the outcomes of heart disease and diabetes. It helped explain what a person's test results meant so they could understand what their numbers meant. And then it gave some recommendations at the end to help overcome any common barriers and address and talked about benefits of making behavior changes that could reduce risk. So I had experience applying it in that way to those kind of conditions, and we actually did a pre and a post test to measure those constructs, and we're able to see that it did make a difference. So that's how I personally had some experience applying the model.
Excellent. And I think that holds true if any of you are working in like a worksite wellness, or even if you've had the experience of doing a health risk appraisal yourself. A part of the dynamic of getting a health risk appraisal is they're bringing to your attention the awareness of those symptoms, as we said earlier, severity, susceptibility. Hey, your cholesterol's 250, hey, your blood pressure is this. That's a little piece of the health beliefs model in action there. Again, pushing people toward action as you relate to them what's going on, making it visible and real for them. Because we know that when people have silent symptoms, like I have high blood pressure, but I don't have any, it doesn't affect how I feel, then I'm not likely to do something, right? So making it real to people. Great. All right, let's move on to our next model then, which is the one that I think most people probably know about. This has gotten lots of press in the last decade. So the trans-theoretical model, or the stages of change model, the technical name is the trans-theoretical model. And I'll wait and see if someone else can tell me why. So I think we're at Angie.
Okay, the trans-theoretical model was developed in the early 1980s by Prohaska. I think I'm saying that correctly. And
it's Prochaska.
Prochaska, okay. And D. Clemente.
Good, yep.
Prochaska and his colleagues evaluated smokers to see that they used the 10 processes to see about the struggles with stopping smoking. And participants used the different processes at different times during their smoking cessation. So the evaluation showed that behavior change happens in a series of stages instead of just kind of all at once. And so then once they studied that, then they were able to identify and categorize the stages that we have now.
Good. And just the title, the trans theoretical model, comes from the fact that, and I kid you not, here again, I read the biography of Prochaska, and he was literally sitting at his house at the Cape, I believe, Cape Cod, and writing ideas down on a napkin out on his porch. Not a bad life, Prochaska. Looking at behavior change theory across all theories. So he put pieces from Freudian theory in there. He put pieces from behaviorism, the classic stimulus reinforcement of the old-time behaviorists. He put stuff in there from the cognitive theorists. And then he looked across those theories, thereby the name trans-theoretical, to try to see if there was a pattern of change that borrows from all of them that could explain people's change. And as Angie said, it's kind of interesting that his group that he was working with was smoking cessation, because that's very different from the last model we just looked at, where it's kind of a one-time screening or the initiation of a behavior. Smoking cessation, as you know, is a long process for some people that takes many, many attempts. And so he was really looking at, why is it that some people get to here and then they relapse and then they start again, and so on and so forth. So what are those key concepts? I think we all know these. Would somebody like to go through these for us? Who's next here? Cassidy?
Hi.
Hi.
You kind of just answered me, which I thought I was answering, so let's go on to see.
Key concepts.
So the key concepts I had, well, we already said how they change, or they think that everything changes over a period of time. So for a person to progress through the different stages that they had, they must apply the cognitive, affective, and evaluative processes to finally achieve a balance and then get to self-efficacy.
Okay. Anything else?
Well, it's made up of the different stages, which is pre-contemplation, contemplation, preparation, action, maintenance, and then the termination. Just briefly, the contemplation is when they really aren't ready at all to make a change or even decide on that. Contemplation is they're thinking about making a change, and the preparation, they plan to take action within a 6-month period. And then, where else is it? And then in the next stage, they finally take that action. And then in the following, it's obvious to see when you're looking at it, it's building on each other. So.
Yeah, and what was really breakthrough about the stages of change was, and you said it before, was that, we used to just assume that people were ready to just change behavior, like turning on and off a light switch. Okay, I go to the doctor and he says, stop smoking, and boom, I just do it. And we've learned that it's really not like that. And also the idea that people go in and out of the stages. So you see how smoking cessation was a perfect population to develop this theory, because it's a kind of behavior that lends itself to that. And I would say, dieting or weight loss is also very similar. Addictions is very similar, and it's been applied a lot to alcohol and drug programs. So it's very different from health beliefs, where we're just pulling the trigger on a behavior to get it going, or to do it once a year, or what have you. This is a process. So they really developed the process of behavior change. And I just wanted to, I have a couple slides here. Can you guys see my screen?
Yes.
Yeah.
How do I advance? Oh, put that. Oh, thank you. Hang on, I'm having technical difficulties also. All right. All right. Yeah, so there's our lovely, I have to show you the mugshots of Dr. James Prochaska. And Carlo Di Clemente, by the way, was his graduate student who then carried on his research to the next piece. It's also, as we said, linked to motivational interviewing quite a bit. There's our stages. That's one of the key concepts. One other key concepts were people able to develop. Who's next after Cassie? So I don't have my chat screen open. Oh, that's okay. No, that's okay. Just like that. Can you guys see it?
Courtney?
My attendees. Yeah, okay. I got it. No, that's fine. All right. Hang on. Where are we? There we are. Courtney. There you are. Other concepts that you want to mention?
Were you talking about the process of change?
Yeah, besides those processes, if you're making your little chart for yourselves on the key, the pieces of the theory. So we have the stages, and then what are some other components?
So the processes, the consciousness raising, so learning new facts, ideas, tips that support the healthy behavior change. And then we have dramatic relief, which is experiencing the negative emotions that go along with the unhealthy behavior that we're actually trying to change. And then we have self-reevaluation, which is realizing that the change is actually important to the person and their identity as a person. And then environmental reevaluation, so realizing the effect it has on the social or physical environment of the person. And then we have self-liberation, making a firm commitment to the change. And then from there, helping relationships, so seeking the social support for the healthy behavior change. And then the counter conditioning, substituting the healthier alternative behaviors for the healthy behavior, so switching it out. The reinforcement management is next, and that's increasing the rewards for the positive behavior change and decreasing the rewards for the unhealthy behavior. And then the stimulus control, removing the reminders or cues that engage the unhealthy behavior. And then the social liberation, realizing that the social norms are changing and everybody's supporting this new healthy behavior. So.
Excellent. Now I'm going to wager that most of you have seen the stages probably more than one time and used it and are pretty familiar with those stages, right? Pre-contemplation, contemplation, and so on. Everyone has seen those, it's fair to say?
Yes.
Mm-hmm. And everyone totally gets what they all mean, right?
Mm-hmm.
Yeah? Anybody have any question on the stages?
I had one question, Meg.
Go ahead.
About the time frames.
Yeah.
Because, like, for instance, in pre-contemplation, and they say it's generally for the next 6 months, but how did they come to that conclusion? Because some people could be in pre-contemplation for a long time. So where did this 6-month time frame come from?
I think it came from the need to statistically measure it.
Oh.
Yeah.
Okay.
And also I think some I guess you guys have read some of the literature where you see, and somebody talked about how they worked in with the dietitian to see how she, assessed the client's stage of change and try to figure out where they're at. So I think the need was to, put some kind of data point around it to define it. If you guys have seen articles on this, you'll see how they have these algorithms. Has everyone seen that or not? By an algorithm, I mean like, they plug all the stuff into a formula and then they figure out, oh, that person's in contemplation or that person's in preparation. But typically, they use 30 or 60 days as windows to mark those things so that, it might take me like 30 to 60 days, or, 30, yeah, a month to 6 months until I'm ready to make that change to that next phase. And that's really, I think, just to quantify it, to say that's where that person is. And also, reality bears that out for probably most people when they've, study this and look at how long it typically takes people to move from one stage to the other. But I totally agree with what you're saying, because some people, they'll be in denial and then all of a sudden, boom, how do we know how long that took for them to move to that stage? So I think they're rough estimates of behavior where they've been able to study it. So we all know the stages, right? It's interesting to think about the fact that some stages, or some behaviors rather, never truly have a termination. So in some things, like there's a new text I'm using for health promotion with my undergrads, and they don't even put termination in there as a phase. Because like healthy eating or something like that, there's no end point. But if you think about, it was developed on smoking, so that's why it's in the original theory. So that's why termination relapse is in there, but it doesn't apply to every single behavior. Or like, we want somebody to exercise. There's no real termination to that. So think of that, and then I want you to think about, what is
because if you move over to the other screen,
okay,
you have to reactivate this.
Oh, so just click on it.
Yeah, so it knows it's.
I gotcha. So here's something I want you to think about. And this little fact is in our chapter somewhere. 75% of all health behavior programs are directed towards action stage. In other words, we treat the client as they're ready to go into action. But at any one time, only 25% of people are in the action stage. So let that sink in a minute. What does that mean? Who can tell me? What do you think? 75% of programs are geared toward action, but only 25% of the people are in action.
The rest of the people are in pre-contemplation or contemplation.
Yeah, so we're missing the boat, or preparation. Yeah, so the real challenge is to, if somebody's in action, then our role as an educator, an informer, an advisor, somebody that's going to give people information, that's really critical. But if somebody's in pre-contemplation, contemplation, or preparation, then giving them tons of information may not be very helpful. They might need something else. Because remember, what we're really trying to do, and this is what makes this model so nice for practitioners, is we don't have to get people all the way from A to Z. We just have to move them one step at a time. So I think the fact that Prochaska and Di Clemente showed us the process of change, that it is in fact a process, was really key. And no wonder everyone's using this model. So does anyone have a comment on that? about the 75-25.
I have a question.
Yep.
Can you hear me?
Yep, I can.
This is Amanda Kraus. Well, what would be an example of that? Because when I'm thinking about that, if I think about smoking, I mean, I don't think about health promotion programs that target smokers who have already changed, who have already quit smoking. I normally think of them as being in the preparation stage, or even with weight management, I would think of it more in that they're in the preparation. The programs I can think of seem like they're designed more for people in preparation than people who have already changed behavior, even if it's a new change. So it would be an example of like a health program that is designed for someone in the action stage.
Well, it's
kind of what I'm asking.
Yeah, it's kind of like we're assuming that people are all ready to go, and we haven't really explored some of the other, some of those barriers. So if we go too quickly to action, the typical example is the dietitian that comes into the client in the hospital and hands them a diet, and he says, here you go. That's assuming they're in action, and they might not, and I'm not knocking it because I've been there, but you might not have taken the time to explore what is that person's motivation, what is their barriers, what is their holistic health, like some of those other things that people articulated tonight about what they want to do, not just their physical health, but what's going on for them with psychological issues or loss or depression or what have you. So, really finding out, are people ready to go? If somebody's just thinking about what they want to do, you want to give some developmental things to help them prepare and be set up. Like just the act of, if I'm working with a client, I like to have them start, I'm talking about nutrition now, to prepare to begin to eat well. The first thing I might have them do is go through their pantry and throw out all their junk and go to the store and bring new healthy foods into the house. So they're going to have to commit to do that before they're going to commit to start eating it and following it. Mm-hmm. That would be an example. Or the example is like when the doctor says to the client, you should stop smoking, but doesn't give them any tools on getting themselves ready. Here's an array of nicotine replacement products. Do you know about the quit line? Have you thought about this? Where will you get support? Since all your friends and family smoke, how will you talk to them about that? So those are the kinds of things that I'm talking about, getting them really prepared rather than jumping right into action. Does that make sense?
Yes, thanks.
Okay, so this slide is just saying about motivation, and I think I just said this, that we have to tap underlying motivations rather than trying to create motivation for what our agenda is. Now, we just looked at those 10 processes, and I know that people are familiar with the stages. How many of you were familiar with the 10 processes? Anybody?
Nope.
No.
Okay, so here's where the trans and trans theoretical comes from. So notice consciousness raising, bringing something into my awareness. Who's that coming from? What theorist?
Freud?
Freud, yeah. So Freud was the one that said, there's so much going on in people's lives that everything's not in their consciousness. We have to bring it to their consciousness. So a lot of our public health campaigns with billboards and advertisements and cues like we saw in the health beliefs model, that's to raise consciousness or raise awareness. So that comes from Freud. I won't go through all of them, but somatic relief, also a cognitive theory. The environment, looking at your environment, that's behavioral. Change the environment and that'll change your behavior. Conditioning, counter conditioning, that's strictly behavior mod. reinforcement, stimulus control. Those are all right out of the behavior modification playbook. And then some of those others are cognitive theory. So that's where the processes come from, and I want everybody to see that. And then those little dotted lines that you see on the slide, that's where I added all of the coaching functions. So in other words, if someone's in pre-contemplation and I need to move them to contemplation, how do I do that? Well, the skills that really help that are listening, empathy. So it sounds like you've been depressed since you lost your mother, right? Empathy, acceptance. You know, I'm not pushing you to do a program. I'm accepting where you're at right now with your health. What would you like to see happen? See, these are all the kinds of things a coach would say as opposed to a practitioner, a traditional practitioner. There's that inquiry again. We talked about inquiry a little bit 2 weeks ago, how that's a coaching approach is, you know, I'm curious about you and I'm curious about what you would like to achieve. At appreciative inquiry is one of the theories that coaching uses. It's not in our textbook, but that'll be in the future. Reflection. If you guys, I don't know what your background in counseling skills are, but if you only ever learn a couple of skills, listening and reflection are really, really important to let the client know that they're being heard and that you're with them. We call it withness. And that comes from Carl Rogers, the Rogerian theory. So I know I'm throwing a lot of theories out at you tonight, but I just want you to see how much there really is to the depths of all of this coaching. It really does have, we're really at the tip of the iceberg, but we're going to go much deeper. Affirming. I just taught this skill to my undergrads today, and the literature tells us that we don't do enough of it. So we need to, here again, give positive strokes, and that's reinforcement. That's one of the processes where, you know, gee, I'm really glad you even came in today. It's great that you're thinking about this. In other words, not pushing the action or the doing, but even that you're thinking about it. I'm proud of you that you're preparing to make a change. Those are affirming kinds of things. And by the way, these slides are in the slideshow that I put up on the first week. So you guys already have these. They're on Blackboard. I just went a little bit further in the presentation to pull out these stage of change ones for tonight. So notice those would be the coaching functions we would use to move someone from pre-contemplation to contemplation. And then moving from contemplation to preparation, we would use things like building self-efficacy and going through barriers. Let's go through all of the obstacles and knock them down one by one. Let's strategize. Let's plan. What gets in the way of you injecting your insulin? What gets in the way of you doing your physical activity? We will talk much more about self-efficacy on our next video conference. It's the key component of our next theory, social cognitive theory. So don't worry, I won't belabor that tonight, but I will belabor it in 2 weeks. So you'll learn all about self-efficacy. And then notice at the very bottom, how do we finally move someone then from preparation to action? What are the coaching functions there? Experimenting, again, that discovery kind of learning, and brainstorming. That's where coach is really helpful. Remember we said work as a sounding board. So just let the person, you know, free fall. Like what are some ideas you have? What would you like to do? A powerful question. If you could see your ideal self a year from now, what would it look like? You know, so that's an example of a coaching question, a powerful question, we call it, that would get the person brainstorming. And experimenting is developing those really good trial and error kinds of activities for them to see, oh, this really worked for me, this didn't work for me. So to go back to what Amanda said, all that should really come in before we launch a person into action. But usually we don't build up to that in that way, at least not in traditional change. Let me shut up for a minute and would you guys like to comment on this slide at all? What's your experience with these processes or moving people? Let me ask it this way. Do you have the skills right now to know how to move people from one stage to another? Or is it more of an abstract theory that your understanding of the stages? Anyone want to comment?
I just have a question.
Yes, Whitney.
With regard to the time frame, so if we master these skills and we can move people, is it possible to move people from pre-contemplation to contemplation to preparation to action, like, more quickly than what's outlined in the stages change model?
Yeah, the other model is kind of just, like I said, giving a
reference for research.
A reference point. Okay. Yeah, it doesn't mean the person's got to be there for 6 months before you can move them. Some people move very quickly through the stages, and also they can relapse and go back. Usually they don't go all the way back to pre-contemplation, or denial is another term for it, but they might go back to just like, contemplation. They get caught up in their head like, oh, I'm going to do this and this and this, and they get out of action because they're overthinking it, right? You know that old expression, analysis paralysis.
Yeah.
I look at it. I've looked at it from so many ways that I'm unable to act. So that's a great question. Anyone else have a question now about how all this comes together for coaching?
I have a question, but it's kind of not related to that. Just something I'm thinking about. How does fear of stuff come into play with all this? Because I know for me, I'm absolutely petrified of needles. It took me 3 years to get my wisdom teeth out. I faint in the doctor's office talking about it. So for me, it's not even that I don't want to overcome it. I'm just petrified.
Yeah. Well, that would be, a barrier that you personally have, right? So you could think of it as a barrier. And then how would we get you past that barrier? So we would use those first set of skills. So I would say, Cassidy, I totally get it. I understand that you're afraid of needles. It sounds like that's something that's, really hard for you, right? So I'm listening, I'm empathizing, I'm accepting you. You're feeling listened to. I'm saying, well, now when you did finally get your wisdom teeth out, or, you did get this vaccine, what happened that made it doable, or what made it better, or what helped you, right? And then I'm working with you to build your confidence, your self-efficacy, so that you're able to overcome that barrier. But I'm really taking the time to talk it through with you. I'm not judging you, and I'm not saying, well, you should get that, you young lady, you must get over that fear, or, back to granny.
Yeah.
So I'm taking you in as a whole person, and I'm responding to that.
Okay.
With regard to building self-efficacy, what are some, I know you kind of touched on it just now, but how do you, I can understand sorting barriers, but how do you get someone to recognize that they can take action? What are some methods to do that?
Oh, there's a whole specific list of things that affect it. Just real quickly, successful past performance. So that's why I said to her in the past, when you were able to do it, effective persuasion of the coach, someone who's, kind of trusted figure that is encouraging you, modeling. You see other people and they do it and they're okay, and that gives you some strength to do it. So there's again, like this, there's a list of factors, and we can translate those into actual behaviors. So, yeah, that's a good point. So what other things strikes people about this, looking at this model in a much more detailed fashion on these these processes? Any other comments?
I have a comment, Meg.
Go ahead.
Well, in my work at the substance abuse center, where I get to meet with the patients for about a half an hour.
Yeah.
So sometimes I am in a position where I might be able to see them again, but often this half hour with them might be the only time I ever see them. And looking at the list here, I just naturally do the beginning 3. Like, I didn't know I was doing this. I just do it, the listening, empathy, and acceptance part, because half the time they're angry that they're even in the room with me. They don't know why they're there with me, because they're there for something else. So I kind of learned over time that if I didn't take the time for those things, they wouldn't even talk to me. But then it's like, how do I even do it? It feels like I'm kind of stuck in time, because you need so much time to move through all these steps. So I tried to just come up with, I want to give them the information, because especially a lot of them don't have health insurance. They might never get the information again, but they're in pre-contemplation. So I try to just give them the handout and like go over it really quick, and then say, I just only want you to think about this in the context of your life, or something like that. Like telling them they don't have to do this yet, but is there a way you can use these things in a short term? You know, is there a more effective thing I could be doing?
Yeah, what I usually do is I say to people in a situation like that, where I'm not going to have a chance to be with them over time, I might say, what would be the next step that you could take to do X, Y, or Z? Or what's one thing you're willing to think about changing? So we're really, bringing the focus in and making it really doable, and notice it's coming from them. I'm not saying, here, do number 1 on the sheet. I'm saying, what's one thing that you might be thinking about changing?
Yeah, that makes sense.
So try that, and then at least maybe you get a dialogue where they're starting to move, because what we're looking for in stage of change is creating a little bit of motion, just getting a little bit, nudging them a little bit. Anyone else want to comment? How you view stage of change, or any insights into this? Anybody? No? Okay.
I have a question.
Go ahead.
Hi, it's Erica.
Hi, Erica.
What happens when an individual slips from the maintenance stage to the pre-contemplation stage very quickly? What do we do?
Yeah. Have you observed that happening?
No, actually, it was kind of a
theoretical question.
Pardon me?
Is it more a theoretical question?
It's a theoretical question, yeah, but I'm looking at the stages over and over and over, and I'm listening to my cohort here, and I'm like, wait a minute, does this ever happen, and what do we do? To me, that seems like we've got to jump into, oh my goodness mode, because that means something significant has happened. And I don't mean, again, if somebody's parent has passed and it's completely changed your life, but what do we do when, just in general, they're going along, they've made a major life change and it's going well, and then all of a sudden they just slip into the pre-contemplation stage?
Yeah, I'm not saying that it never happens, but in my experience, people don't often go all the way back to pre-contemplation. Usually if they fall off the wagon with whatever the behavior, smoking relapses extremely common. But they don't go all the way back to pre-contemplation because they've already been past that. So it's on their mind. So they're at least, you know, and in some ways it's worse because they feel like a failure. So they're in, you know, when you have that failure syndrome, you're in contemplation because you're thinking about how hard it's going to be to get back, and you're thinking about how you're disappointing to yourself that you've fallen back. I suppose people can go all the way back to denial, but I think most times they go back to contemplation. And so then we will just bring our arsenal of things out again of listening, empathy, affirming, like just what I'm saying now to you, like, oh, it must feel really hard that you were smoke free for 6 months and then you got stressed out and you must feel like you've fallen all the way back. But you know what? You haven't, because look at all the experiences that you had that were positive. And because you did it once, I'm going to go back to the successful story, you can do it again, you know, and affirming them and building them back up again. And also, we didn't talk about reframing, but that's a fabulous skill. So I might say something like, you were smoke-free for 6 months. Look at how much you've improved your health and cleared your lungs out and decreased your risk. And you're already so far ahead of where you would have been had you kept smoking. So, you know, encouraging them, reframing, making them think about it in a different way, putting a different spin on it. And that's how I would work with someone like that.
I see. Thank you. And that makes sense that you wouldn't normally, I mean, most folks are not going to slip all the way back to the beginning. That makes sense.
Yeah, it's hard to, you know, once they've come out of the denial, it's hard for them to totally go back to it because they've, you know, gone through this program, and you know, I have seen it happen, but it's rare, I think. Does anyone else want to chime in on that?
Meg, this is Mand again. I just wanted to say that I think there is an advantage even in just presenting the stages of change to clients and allowing them to identify where they are and empowering them with kind of knowing that it is a process and that this is a process for most people. Yep. Behaviors just don't happen, but just identifying where they're. And there's something about that even, I know, in personal experience, having used it with clients, and then in my own life when I even have a goal I want to set. Recently, I decided I wanted to teach myself to swim freestyle in the water, you know, with my face in the water, which was something I never learned to do when I was a kid. So learning how to breathe and that type of thing. And I would say to myself, okay, I'm in the preparation stage. I'm going to get my goggles. I'm going to get my, you know, and I knew all the while that it was okay that I was working towards this, and that it wasn't just going to be like, okay, I'm going to hop in the pool and start swimming automatically. So I think there's power in just even allowing clients to understand where they are in the stage and making them aware of the process.
I agree. And you know, I think if you're working with a group of clients who, I mean, some of these terms are a little off-putting if you're working with a group where, you know, maybe the literacy and the sophistication and the wording is too much for them. So I might just say something like, change is a process. Don't have to learn everything today. Don't have to do everything at once. We're going to take it step by step. And even something really simple like that takes a load off the client and makes them hopeful. You know, we're going to set little goals. I love the old African proverb, how do you eat the elephant in your path? Bite by bite, you know. So anyway, so good stuff. Let's just finish this up for the sake of getting all of our questions out. So the other components or concepts to think about, we have the stages, we have the 10 processes, And then there's also these other couple of things kind of thrown in there. Decisional balance. What is that essentially?
I think it's me. So it's weighing the pros and cons, the benefits versus the costs of making the change.
Exactly. And what does that remind you of, Jen?
It was also in the health belief model.
Yeah, benefits and barriers, right? So that component is a part of human nature. We're always going to say, oh, what's in this change for me? And what are the things about this change that are going to be hard for me? And that weighing of pros and cons, cost benefits, whatever we call it, that goes back to Lewin, as I said, the positive negative valence is what he called it, which was not the easiest term, but good. So exactly. Self-efficacy, again, more on that next time. And even temptation is mentioned as another factor. So let's get to part E, because I want to finish up. Where does the trans-theoretical model fit on the health continuum? Michelle?
I guess I would say that it's more in the prevention and promotion part because it provides interventions to help you go through the stages. So like with the smoking cessation or even with the addiction, it gives you the interventions to work on, to make the changes and help you get through it.
Okay. So, definitely prevention. But yeah, I think health promotion, because that could be a lifelong pursuit of changing behavior, getting healthier, or just taking another behavior and going through the stages with a health promoting behavior. Training for a marathon. I might, or just like Amanda just said about swimming, I might go through those stages in my mind to, prepare myself. Even chronic disease management, I think, can use the stages for whatever behaviors the person is working on. So stage of change is very versatile, and it works on any kind of long-term behavior change. Whereas our health beliefs model was a little more geared to a one-time or initiation of a behavior. Anything where there's a long-term process and change is going to have to keep going, and also things happen in the person's life where they have to go back and make some adjustments. So stage of change is really very, very versatile.
That's something else that I had written was it provides the flexibility to move along at the continuum at the individual's own pace. So they move to the next step when they're ready, not as an individual, not as a group. So you don't have to go through it as a group, and then everybody gets to where they need to be on their own.
Good. So I think we kind of answered F, the applications, but does anyone want to mention any other applications? I know we've said weight management, smoking for sure, addictions. I guess, we could throw exercise in there. Now we have our top behaviors, our top healthy behaviors, and conversely risk behaviors. Anything else that people have used it with that you want to comment on? Okay, so we finished that one up, and I would encourage people to make a little table with notes on these theories, because we're going to be adding theories each week. Next time we get together, we're going to be moving on to the part in the book on interpersonal theories, and we're going to talk about social cognitive theory, which is the theory from which self-efficacy is derived, and we're going to talk about social networking, which is a really different, you probably haven't used this theory, but it's used a lot in health services, and especially in non-mainstream populations where using a core social network is really highly, highly important. So I'm thinking of things like Indian reservations and certain isolated social and economic groups. Social networking is huge. If you want to get behavior change to occur, you got to go and get into that network and get yourself out there. So it brings in some of the cross-cultural counseling and cultural competency type of stuff. So I think you'll enjoy reading about that. I think the discussion questions for the next module are pretty much the same, but I will put them up for you, or I'll put in, if there might be one or two that are a little bit different. But we're basically going to go through learning the authors, the origin, the concepts, what it applies to, and hopefully you're going to start to really develop quite an understanding, an in-depth understanding of theory. That's my hope. As painlessly as possible, always. So any other parting comments or questions before we leave tonight?
I know 2 weeks ago you mentioned about the project that we have, and you touched briefly on like ideas or whatever. Is that something we should start like thinking of ideas now and letting you know, or waiting a little more?
I'm happy to, if you want to run something past me that you're thinking about, I'm happy to talk with you now or whenever about it. But yeah, as you're looking through the book and you're looking at these theories, what you'll do is a short presentation for the class, about 12 minutes or so, and then a little bit of time for questions. So each person will have about 15 minutes, and you'll go into the literature and find current literature about one specific theory applied to one specific health issue, because I want it to be a laser focus. So I'm going to look at stages of change with smoking. I'm not going to have one article on stages of change with smokers, one on stages of change with weight loss, and one on exercise. All of your things should be about one specific population. And as much as possible, don't mix them up. Like if you're looking at weight control, look at adults or children. Don't have studies of all different groups mixed in, because we really want to, at that point, see how the theory functions in a very specific focused group and a very specific behavior. What did they find? How did that theory work? And I would encourage people to not just stick with the ones we're covering in class. I mean, that's fine if one of those really speaks to you and you want to learn more about it. But there's some great theories in here that we won't have time, unfortunately, to address. So I just picked out the ones that are most used in coaching, which are stages of change, social cognitive or self-efficacy, and then positive psychology, which we're going to talk about from our other book, not next time, but down the road. And that's the book on by Martin Seligman. And he has another book out that's more recent. It's Authentic Happiness. That's about the theory of positive psychology by Martin Seligman. He has Learned Optimism is his newest book, but for this class I wanted us to go back to his initial work because it's the foundation of his theory. I think you'll really enjoy learning about positive psychology if you haven't learned about that theory yet. It's really refreshing, and it's a real key to coaching. So I hope I answered your question. So you can check it with me if you have some ideas. Read the literature, get out of the textbook, and start looking at some current articles that apply to these theories so that you can start to see what's interesting to you. Okay? And also,
Meg, does it have to be nutrition related?
No, not at all. Nope. It can be any health behavior.
Okay, thanks.
In fact, yeah. Go crazy. Don't stay with nutrition. Bust out. Okay? I'll stay on if anyone has a personal question. Otherwise, I'll see you in 2 weeks. I think we're getting the hang of our go to meetings. So see you then.
Thank you.
Thank you.
All right.
Bye.
Good night.
Bye.
You're welcome. Yeah. Turn off the record. No, I wanted to